I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for March 2016, Advancing Health Disparities in Early Childhood. Thank you for joining us. First, a few housekeeping slides. We do have CE credits available for this presentation for physicians, nurses, pharmacists. Please check out our Public Health Grand Rounds website for additional information. And we have nothing to disclose. In addition to our website, we also have available on our social media sites, and we are live tweeting today. So please use hashtag CDC Grand Rounds for any tweeting needs you might have. We have a featured video segment called Beyond the Data that will be posted shortly after the session. This month's video includes my interview with Dr. Ross Thompson. Thank you very much. We also have partnered with the CDC Library to feature scientific articles related to the topic. Please check out the cdc.gov/scienceclips website for additional information. Here is a preview of the upcoming Public Health Grand Rounds sessions. Please join us. In addition to our outstanding featured speakers, I'd like to take a moment to acknowledge all the hard work and important contributions of the individuals listed here. Thank you very much. And now, for a few words from CDC's Director, Dr. Frieden.
Our genetic makeup makes each and every one of us unique, but factors that affect our environment and behavior have a much bigger impact on our health. These differences influence health outcomes throughout our lives, and they lead to health disparities. Today, we're focusing on health disparities in early childhood. Effectively addressing these disparities offers many opportunities to help children and benefits society as a whole. CDC's Adverse Childhood Experiences Study, which assessed links between childhood maltreatment and health and well-being later in life, suggests that certain experiences are major risk factors for leading causes of illness and death, as well as for poor quality of life. It's important to study not only what can harm children and document how early childhood experiences are formative, but also to figure out what more we can do to improve children's future. This requires engagement by the many influencers of child development: parents and other caretakers, teachers and schools, healthcare and social service providers, as well as community leaders who influence a neighborhood's environment. We all have a role to play in ensuring the future health of the children of our communities. There are also opportunities to work with the child's developing mind to provide experiences that increase their potential, to build a platform that improves many aspects of their lives and their health, as children and as adults. Economist and Nobel laureate Dr. James Heckman notes, "Skill begets skill. Learning begets learning. Advantages accumulate." The Preschool program in Michigan in the 1960s provided disadvantaged children with high-quality preschool services. It's an example of lifelong impact. Children from the Perry program were more likely to graduate high school, less likely to have been arrested, 3 times more likely to own their own home, and earned significantly more than their non-program peers. Analysis of this program and others like it show that for every dollar invested, society gains many dollars back, in addition to improving the lives of children, their families, and their communities. High-quality interventions early in life make the most of every child's potential. We need to further support these programs and ones like it and better coordinate systems to help children's opportunities match their development and their needs. Thank you.
And now for our first speaker, Dr. Ross Thompson.
Thank you for being here today. How to better address health disparities in early childhood is tied to the broader question of how to make systems of care function better for young children and their families. To consider this question, I'd like to draw on the conclusions of a report of the National Research Council and Institute of Medicine released last March, entitled Transforming the Workforce for Children Birth to Age 8. The committee's charge can be straightforwardly and provocatively stated. How do we provide young children with continuous, high-quality support for their development and learning from birth to age 8 by transforming the early childhood workforce and changing systems of early care and education? The emphasis on birth to age 8 was stimulated by increasing understanding of the importance of the early years for later achievement and lifelong success. I'd like to highlight 3 conclusions that came from this report as a way of framing my comments today. First of all, the report concluded that young children's development is deeply integrated. Cognitive, social, and emotional development, along with physical health, are directly connected in shaping young children's capacities to learn, to get along with others, and to develop physical and mental health. Secondly, practitioners in all fields have not kept pace with the rapidly expanding knowledge of early learning and its influences. Developing language and literacy skills have very early roots in the social experiences of infants and toddlers, for example, in which they're acquiring a sense of the semantics and pragmatics of spoken language well before they've even uttered their first word. These early achievements prepare the child for the vocabulary explosion that will occur after 18 months of age, as you can see here, and which enables the child to acquire language skills at an astonishing pace by age 3. Young children are also rapidly acquiring concepts of physical causality, developing a sense of what goes on in people's minds, and laying a foundation for numerical awareness from these early experiences. Processes of early brain development help to explain these remarkable gains. Research in developmental neuroscience shows that significant developments in behavioral functioning are based on emergent neurobiological processes in the early years. This chart documents some of the more fundamental achievements, distinguishing periods of neuroproliferation from subsequent periods of neural pruning by which the brain functions become more specialized and committed. So beginning prenatally and extending through middle childhood, you can see the development of basic sensory processes, language, higher cognitive functions such as logical reasoning, and self-regulatory capacities. Although these timetables vary, the first 2 years of life witness foundational achievements in each of these areas, and this becomes even more apparent when we consider the first 5 years of life. Children's everyday experiences with adult caregivers also provide a foundation for these conceptual achievements. Hart and Risley found that by age 3, children in the highest socioeconomic families had a vocabulary that was more than twice the size of children living in less advantaged families. And their research and other studies have shown some of the reasons why this is true. Children living in more economically secure settings have adults who use language to expand on the child's experiences by talking about the day's events, reading stories, or commenting on shared experiences, by contrast with using language primarily to direct or manage the child's behavior. And these findings have now been replicated by Anne Fernald at Stanford University, finding that the socioeconomic gaps in language occur even earlier ages and are apparent in Spanish-speaking as well as English-speaking children. And the outcomes of these experiences are important. Age 3 vocabulary size is a good predictor of children's reading scores at grade 3, which is in turn a predictor of children's high school graduation rates. In other words, the effects of early experiences of language are compounding over time, especially in families that maintain and reinforce these early influences, but also in those in which these reinforcement processes do not occur. These early influences thus have long-term consequences. This chart summarizes the analyses of the panel study of income dynamics by Greg Duncan and his colleagues. They documented the long-term effects of growing up in a family with different income levels. And as you can see, poverty in early childhood is associated with fewer years of completed schooling, poorer health, and greater likelihood of non-marital birth compared to children living in non-poor families. They were also able to distinguish the effects of early childhood poverty from the effects of poverty when children were older. Early childhood poverty has a differentially significant influence on adult earnings and annual work hours compared to poverty at later ages. Now, a third major conclusion of the NRC IOM report is that the system of early childhood services is fractionated. It is splintered in at least 2 ways. First, there's a splintering and vertical fractionation in which practitioners working with children at different ages have limited interaction with practitioners who worked with that child earlier and also who will work with that child later, resulting in poor alignment of learning experiences and expectations so that developing skills really build on each other. But there's also horizontal fractionation, in which practitioners working with children in different settings poorly communicate with each other and with practitioners in other settings serving the same child. And thus there is limited coordination of services so that assistance in one setting is supported by other service settings. It is also true that family engagement doesn't often occur in any of these service sectors, where families might ordinarily help to contribute to the integration of services for children. This doesn't happen because families are often not part of these service delivery models. The system of services is especially fractionated for the youngest children. The younger the child, the less likely are children and families able to depend on services that provide support in a coherent and integrated manner to benefit the child. The data before you describe the experiences of children in poverty living in California, but the conclusions are generalizable to children in other states and in different socioeconomic conditions. And as you can see, throughout the first 5 years, children transition between multiple care and education settings, sometimes moving from one setting to another within the sector. Young children of any age are likely to be in a diverse array of different care settings, making it difficult to establish linkages between these settings and other social services in a coherent manner. Young children and their families also face other challenges. Parents of young children are typically stressed and are overwhelmed. High-quality childcare is expensive and inaccessible in many communities. Formal and informal providers of care for infants and toddlers are often underprepared and are poorly supported. There are other challenges that young children and their families face that make them more distinctly vulnerable to health disparities than are even older children in the birth to age 8 continuum. Families may lack a medical home, especially if they are living in rural areas or face language or cultural barriers to medical access. Special health care needs present at very young ages, but many young children do not receive services until they enter school. And stress and trauma in early childhood manifest as behavior problems that may not be recognized as mental health needs in young children. Poverty is associated with a wide variety of stresses for young children. So also are other conditions of adversity that affect children in the early years. Consequently, young children are presenting in pediatric care and education settings showing the behavioral signs of stress and trauma and threat. Based on the work of Helen Egger at Duke University Medical Center, what you see before you are estimates of the prevalence of common forms of psychiatric disorder for preschoolers ages 2 through 5. Although the prevalence rates are somewhat lower than what is found with adolescents and adults, you'll notice that up to 16% of children of the youngest ages present with a behavioral profile warranting a psychiatric diagnosis. Egger's work also confirms the association of chronic and severe stress with psychological disorders in young children, and that the incidence of a psychiatric diagnosis rises with the frequency of recent stresses in the child's experience, as well as the frequency of stressful events over the course of a child's lifetime. What, therefore, can public health systems offer young children and their families? Several things. They can increase the emphasis on birth to age 5 for prevention and health promotion. They can increase awareness of early physical and mental health issues and highlight gaps in our knowledge base. They can also communicate prevention strategies to parents and practitioners. They can also strengthen developmental and behavioral health screening and referral services, especially to hard-to-reach and underserved populations. They can establish connections between behavioral and physical health of young children and the connections between these and the health of their parents, and also to broader aspects of community wellness, which are very important. And they can also provide avenues for the development of integrated service systems, connecting pediatric, mental health, child welfare, and early care and education practitioners in ways that you'll hear more about this afternoon. The range of evidence-based programs with demonstrated cost-benefit savings and scalability is now larger than it has ever been. In other words, we're at an historic moment in our knowledge base for actually being able to implement well-designed and verified programs. The 2 programs I have listed here are representative of many such programs in 2 domains: home visitation and early childhood education. Representative of home visitation programs is a well-known nurse-family partnership in which home visits by registered nurses to first-time mothers, particularly those in difficulty beginning in pregnancy and continuing on throughout the child's second birthday, is a means of improving maternal health care practices as well as improving children's developmental outcomes. And indeed, 3 randomized controlled trials have demonstrated benefits for maternal health practices, parenting competency, and child cognitive and behavioral outcomes through adolescence. Cost effectiveness has been confirmed for high-risk families, and this model is currently implemented in more than 20 states as part of the administration's maternal, infant, and child home visitation program, as well as abroad. The Chicago Child Parent Centers are representative of the variety of early childhood education programs that have shown similar benefits. In this program, half-day preschool beginning at age 3 with small classes, well-trained teachers, and a required parent volunteer commitment consist of efforts to help improve children's school readiness. There's also a staff liaison who fosters family outreach. And evaluation studies following these kids long-term have found that benefits to children include improved school readiness, higher reading and math achievement scores, improved high school graduation, and reduced juvenile arrests. Cost-benefit analyses indicate significant savings at a 10-to-2 ratio. There's also a follow-on program for these children to help them transition to the early primary grades. As these examples illustrate, cost-effectiveness studies show that well-implemented early interventions can show a significant long-term return on investment. I emphasize well-implemented. This is especially true for children at greatest risk, and by well-implemented and high quality, we're focusing on things like adult-child interactions and the quality of the social climate in the classroom environment. In addition, we found that subsequent experiences following on after the program is completed have a lot to do with maintaining those early benefits and helps to continue with early gains. And programs like these are especially beneficial when they focus on the growth of multiple skills. In other words, both cognitive achievements, but also the non-cognitive skills that foster children's continuing learning. The quality and quantity of evidence-based early interventions for young children and their families continues to grow, which makes this an optimistic time. Now it is my pleasure to introduce Dr. Paul Dworkin.
Thank you very much, Dr. Thompson. As we have heard, the explosion in our knowledge of early brain development and early child development, so widely disseminated in the 1990s, the so-called decade of the brain, has profound implications for how we design our programs, our services, and our systems. Furthermore, our enhanced understanding of the determinants of children's healthy development demand that we acknowledge the finite contributions of quality health services and address the critical influence of social and environmental factors, genetics, and individual behavior. Another critical concept in early child development is that of developmental trajectories. Neil Halfon notes that most of our clinical and our policy attention is directed at the 12 to 16% of children progressing along a so-called delayed disordered trajectory. He describes the majority of children as fortunately progressing within the broad range of a healthy trajectory. Halfon also importantly identifies a subgroup of vulnerable children, estimated at 30 to 40% of the population, who are progressing along a so-called at-risk trajectory. Such children typically do not fulfill restrictive eligibility criteria for our publicly funded early intervention, preschool, special education, and children with special health care needs programs. For vulnerable children progressing along an at-risk trajectory, positive experiences may serve as protective factors and ultimately enable them to ascend to a healthy trajectory. More commonly, however, adverse circumstances increase risk and result in the eventual deterioration of such children to a delayed disordered trajectory. The important implication of this early child development concept was first articulated in 1992 by pediatrician Robert Chamberlain. The most effective long-term strategy appears to be the development of a comprehensive, coordinated, community-wide approach focused on preventing low and medium-risk families from becoming high risk, as well as, of course, providing intensive services to those who have already reached a high-risk status. Our story of system building began in Hartford, Connecticut during the 1990s, the decade of the brain. The state of Connecticut has the highest per capita income in the nation. Yet Hartford, the state capital, is currently ranked the country's 7th poorest city of more than 125,000 residents. And poor housing stock with dangerous lead burden is one of many adverse influences on our children's healthy development. With support from a local foundation, the Hartford Foundation for Public Giving, we undertook a series of crucial conversations on how to strengthen child health services to promote our children's optimal healthy development. Key informants included public officials, child health providers, child health advocates, community-based organizations, parents groups, and the state's early intervention program, Birth to 3. We were impressed by how quickly discussions yielded shared assumptions that informed our efforts at system building, that children with developmental and behavioral problems are eluding early detection, that many initiatives exist to provide services to young children and their families, even in relatively resource-poor venues like Hartford, that a critical gap exists between the best efforts of child health providers, early care and education, and family support providers to identify such children and the linkage of such children and their families to community-based programs and services, and that children and their families would benefit from a coordinated region-wide system of early detection and intervention for children at developmental risk. To address our assumptions, we devised a 4-component model for pilot study, and Help Me Grow implementation today is predicated on fidelity to this model, including its original 4 components. Child health provider outreach strengthens skills in early detection through training in developmental surveillance and screening. Community outreach engages parents and organizations to capture the region's developmentally enhancing programs and services and inform families as to their availability. The heart of Help Me Grow is its centralized telephone access point, a common portal of entry to the full array of developmental and behavioral services available to children and their families. And the 4th core component is data collection and analysis to both document the impact of Help Me Grow and to identify critical gaps, capacity issues, and barriers to inform advocacy and support of system building. The success of a Hartford pilot study from 1997 to 2002 led to incorporation of Help Me Grow within the 2002 state budget as a statewide program that continues to be supported today. Child Development Infoline, a specialized information and referral service of United Way of Connecticut, provides a central portal of entry to the state's developmental programs and services. Child Development Infoline care coordinators skillfully link children likely to meet specific eligibility criteria to publicly funded early intervention, preschool special education, and children with special health care needs interventions. Vulnerable children at risk for adverse developmental outcomes, but likely ineligible for such services, are linked to community-based programs and services through Help Me Grow. Annual evaluation reporting on numerous process measures documents that Help Me Grow fulfills state requirements for results-based accountability. For example, since 2002, greater than 80% of children and families referred to Connecticut's Help Me Grow have been successfully linked to community-based programs and services. The majority of families who contact Help Me Grow reside in the urban periphery and the urban core of Connecticut. These towns have the lowest income, the highest poverty rates, and the highest population density. In 2014 to 15, Help Me Grow connected 2,800 children and families to community-based services and provided access to developmental screening through the Ages and Stages Child Monitoring Program to 3,000 families. Beyond process measures, we must also determine whether Help Me Grow achieves its mission to promote children's healthy development and longer-term educational outcomes such as school retention rates. High school graduation are not yet accessible for Help Me Grow supported children. Research has examined the extent to which Help Me Grow's linkage of children and their families to community-based programs and services enhances protective factors. Such factors are valid proximate measures that mediate such desirable longer-term outcomes as developmental status and academic achievement. Independent evaluation of Help Me Grow has applied the protective factors framework of the Center for the Study of Social Policy's Strengthening Families Initiative. Research reporting a strengthening of parents' perceptions of protective factors is currently in press. In this table, select survey questions indicate that parents report that Help Me Grow linkage strengthens their knowledge of parenting and child development, resilience, social connections, concrete support in times of need, and children's social and emotional competence. Success in Connecticut has resulted in requests from other states for technical assistance to replicate Help Me Grow, and in 2010, with support from the W.K. Kellogg Foundation, we established the Help Me Grow National Center at Connecticut Children's Medical Center to support replication efforts with the eventual goal of enabling all interested states to develop Help Me Grow systems. At present, more than 25 states and territories are affiliates of the National Center. The Help Me Grow experience in Connecticut and across the nation yields many implications for public policy in support of vulnerable children's healthy development and efforts to address health disparities. We must focus on vulnerable children who often elude early detection and typically do not meet the relatively restrictive eligibility criteria of states' early intervention programs. Critically important are support for interventions that strengthen protective factors and enable families to mitigate the impact of early adversity and stress. And cross-sector collaboration is imperative in addressing the many adverse influences on children's developmental outcomes. States are now embedding Help Me Grow within a variety of federal initiatives, including the Maternal and Child Health Bureau's Home Visiting and Early Childhood Comprehensive Systems, the CDC's Learn the Signs Act Early initiative, SAMHSA's Project Launch, and the Administration for Children and Families Birth to 5, Watch Me Thrive. Our experience with Help Me Grow encourages our broader conceptualization of the many critical sectors of the comprehensive system so important to address families' needs. Unlabeled petals of this flower diagram represent those yet to be identified sectors also crucial to promoting vulnerable children's healthy development. Our key message is that cross-sector collaboration is essential to achieving our goal of supporting the developmental flourishing of all children through system transformation. It is now my pleasure to introduce Dr. Georgina Peacock.
Thank you, Dr. Dworkin. As we've heard from Drs. Thompson and Dworkin, cross-sector collaboration is key. CDC is one part of many federal, state, professional, and community organizations working to promote early childhood development, and we're only listing a few groups here. There are a number of Healthy People 2020 goals related to early childhood. These include fostering knowledgeable and nurturing parents and caregivers, creating supportive communities, increasing access to high-quality health care, and increasing the proportion of children ready for school in all domains of healthy development. These domains include physical, social-emotional, learning, language, and cognitive development. A public approach to early childhood development includes determining how many children have specific disorders and identifying modifiable risk factors. Ensuring early identification and access to evidence-based treatment for children with mental, behavioral, or developmental disorders. preventing the onset of disorders, for example, by targeting known risk factors for these disorders, and promoting health for all children. This framework supports our work in serving children who already have identified conditions, but also those at risk, such as vulnerable children. Last week, we published a report on sociodemographic, family, community, and healthcare factors associated with mental, behavioral, and developmental disorders among 2 to 8-year-olds. And we found that 15% of U.S. children aged 2 to 8 had a diagnosed mental, behavioral, or developmental disorder by parent report. And you'll see a list of these disorders included here. We also looked at the association of family, community, and healthcare factors among U.S. children aged 2 to 8 with or without a mental, behavioral, or developmental disorder. Those with a disorder are in light blue, and those without are in dark blue. We found that children with one of these disorders were more likely to have more negative indicators in all domains. They were more likely to have a parent with fair or poor mental health, have difficulties getting by on their family's income, and have employment problems related to childcare issues. These children were also more likely to live in a neighborhood that lacked amenities such as parks, was in poor condition, or lacked support among neighbors. For example, they weren't able to identify people in a neighborhood to help their child if their child was outside playing and got hurt or scared. And they were also more likely to have inadequate insurance and not have a medical home. This is just one recent example of how surveillance data to help define the problem and to identify factors to target for prevention efforts. An example of mental, behavioral, or developmental disorders that we are addressing here at CDC is attention deficit hyperactivity disorder. The prevalence of ADHD is increasing, and 1 in 3 children are diagnosed before the age of 6. While the American Academy of Pediatrics recommends that behavior management training for parents is tried before medication for 4 to 5-year-olds, only 25% are being treated with medication only. CDC's initiative, Focus for the Future, works to make sure that children with ADHD get the right care at the right time. Only half of children under age 6 with ADHD receive any psychological services, which may or may not include evidence-based behavior management training for parents. CDC works to increase awareness, address service deficits, and inform policy decisions to help families get the care they need. CDC has a number of public health activities to improve early detection and referral to treatment. We know that the earlier children receive needed services, the more likely they are to reach their full potential. Learn the Signs Act Early promotes developmental monitoring and screening to improve early identification of developmental disabilities so children and families can get the support they need as early as possible. Early Hearing Detection and Intervention, or EDI, supports states in developing and implementing tracking and surveillance systems to help ensure that all infants are screened for hearing loss and receive recommended follow-up services. We have also worked with partners to develop tools for clinicians and for parents to improve the earlier identification of muscle weakness and physical developmental delays. Earlier identification allows for earlier access to needed medical care, early intervention services, and special education resources. We have 2 programs at CDC with a focus on promoting positive parenting. Legacy for Children is a group-based parenting program focusing on positive parenting, sharing knowledge about child development, supporting maternal self-efficacy, and building a sense of community. We are working with federal and private partners to disseminate this program. Essentials for Parenting is a free web-based resource for promoting positive parenting and enhancing parent-child relationships, which in turn can prevent child maltreatment, and increase healthy child development. This resource engages parents of children aged 2 to 4 years and uses video demonstrations and interactive activities to build knowledge and skills. The last initiative I want to mention is Essentials for Childhood, which encourages safe, stable, and nurturing relationships and environments to prevent child abuse and neglect and to ensure children reach their full potential. This initiative encourages statewide coordination of multi-sector activities that raise awareness, use data to inform action, and create the context for healthy children and families through norms change. Going forward, we will continue and expand upon our current public health work addressing early childhood in the areas of surveillance, prevention, early identification and referral, and improving access to treatment. We will continue to identify new partners for continued and strengthened collaboration to promote optimal development for all children. And now I'd like to introduce Dr. Mary Ann McCabe. Thank you.
Thank you. I'd like to begin with just a little bit of a history of framing mental health as a public health problem, emphasize some key points, many of which we've heard from our prior speakers, and then end with some key policy recommendations for promoting children's behavioral health. It was as early as 1954 that the first Director General of the World Health Association emphasized, without mental health, there can be no true physical health. And then over 4 decades later, the U.S. Surgeon General's office issued a landmark report that framed mental health as a public health issue. The Substance Abuse and Mental Health Services Administration, with assistance from the National Institute of Mental Health, produced a supplemental report that focused on racial and cultural issues in mental health, including disparities. Importantly, the World Health Organization Constitution in 2006 framed health as a state of complete physical, mental, and social well-being, and not just the absence of disease. This is a really important point. And then following that landmark Surgeon General's report, there was a call to action regarding children's mental health in particular. To quote, "Mental health is a critical component of children's learning and general health. Fostering social and emotional health in children is part of healthy child development and must therefore be a national priority." Briefly, here's the landscape of children's mental health. Most mental disorders in adults can be traced to an onset in childhood. Estimates are as high as 20% of children in the U.S. have a mental health problem, and only 20% of those receive mental health services. This has been coined the 20/20 problem. This situation is worsened by a lack of funding and providers and by gaps in implementation of evidence-based practices. Treatment for some type of mental health disorder accounts for the largest category of spending of health dollars for children. And this does not include additional costs in other sectors, such as education, child welfare, and the justice system. But it's been difficult to obtain significant traction since the Surgeon General's call to action. Perhaps the largest obstacle we've faced is the absence of a clear and unifying definition of child mental health. It's a critical part of healthy development, and it incorporates mental, social, emotional, and behavioral health. The status quo continues to allow knowledge to remain in silos, to contribute to a lack of public understanding of available science, and it has made collaboration difficult. So children's mental health in this broad definition is not confined to a single service sector or area of public policy. It's a broad public health issue and inextricably linked to policies related to health, education, and safety. These programs and policies include areas of child care, education, child welfare, disasters, school safety, juvenile justice, and there are others. Quite simply, child mental health should be addressed where children live, play, work, and grow, wherever children are. So what do we do? In order to promote behavioral health and reduce mental health and health disparities, we need to promote healthy development for all children, including those with specific health conditions and mental disorders. We need to educate the whole community about healthy social and emotional development, not just parents and caregivers. And we need to disseminate and facilitate implementation of evidence-based programs and practices. This new website just launched this week is one illustration of using technology to share evidence-based information. It was just launched by the Consortium for Science-Based Information on Children, Youth, and Families, a collaboration of 7 divisions of the American Psychological Association. The name is infoaboutkids.org. So to promote healthy environments, we need to move upstream with a focus on the social determinants of health and life course health development, and promote healthy environments and early relationships. Prenatal and early life experiences affect adult health. We need to focus in early childhood for promotion, prevention, and early intervention. Research concerning adverse childhood experiences and toxic stress in early childhood are clearly helpful for identifying opportunities for promotion and prevention. And as we've heard earlier, we need to integrate across sectors: health, education, social services, and the justice system. Currently, public policy turns on when there are problems. But instead, policy should look upstream toward mental health promotion and prevention. This will require new financing strategies. And of course, the greatest opportunity for savings is found in early childhood. James Heckman's work, which has already been cited today, is perhaps the most widely used to support public policies for investing in early childhood. Quite simply, the earlier we invest in development, the greater the impact. The President's Council of Economic Advisors have recommended investments in young children, particularly in early education. Now, the Affordable Care Act has built upon the Mental Health Parity and Addiction Equity Act in advancing insurance coverage for mental health and substance abuse services. It has stimulated attention to mental health promotion, prevention, and access to evidence-based care, and it has facilitated a 2-generation approach. There still is, however, a state patchwork of coverage. There are multiple opportunities in the Affordable Care Act for a 2-generation approach to health. There is an emphasis on a family-oriented approach, including that educational achievement is correlated with improved adult health. It's important to support education and employment opportunities, not just for growing children, but for parents. And there can be a focus in the Affordable Care Act coverage on the health of the most vulnerable children and their parents. That includes expanding Medicaid coverage, fostering improved outcomes for both parents and children through home visiting programs, screening, diagnosis, and treatment for both child and adult mental health, and integrating health with human services in communities. The National Academy of Medicine has convened a forum on promoting children's cognitive, affective, and behavioral health to advance implementation of evidence-based programs and practices. The CDC is among the sponsors of the forum. And now some recommendations. We need linkages and blended funding streams across health and education, primary care in schools, and healthcare and community programs. Linkages across sectors will accommodate the reality that an intervention in one silo affects outcomes in another. This relates to the problem of fractionation that Dr. Thompson introduced and that Dr. Dworkin's model illustrated. Linkages will require innovative financing strategies, including blended funding streams. Number 2, behavioral health should be fully integrated into primary care. This will require innovative ways to promote child mental and behavioral health. School-based health centers need to be funded to provide behavioral health services along with federally qualified health centers. Here's a few more examples of that two-generation approach that I was mentioning. It will be important to promote prenatal development and healthy parenting and attend to parental depression in the primary care setting. It'll also be, of course, important to screen for behavioral health during well-child visits. My third recommendation, it's important to educate adult health communities about the life course health perspective, promoting healthy child development for lifelong health. As we've heard, early childhood, positive parenting, and prevention are in the mental health goal of Healthy People 2020. Number 4, we need to measure return on investments with children and families, accounting for development and future targets, like health, educational attainment, and work productivity. Timelines for return on investment are often determined by budget and funding cycles rather than expectations regarding outcomes. And finally, number 5, policymakers should focus on those children and families who are at risk rather than those who use the most services. A change in policy focus will be necessary to improve population health. And now I'd like to introduce Dr. Peacock back to the microphone. Thank you.
Thank you. So everyone, as we've heard, can invest in early childhood to improve outcomes. Those are community members, care providers and practitioners, educators, and parents, and together we can make a difference. So now I think we turn it over to Susan, who is going to give us some questions from the web audience.
Thank you. Would it not be extremely beneficial to early childhood development to have blood lead levels checked or required as part of annual visits? In general, why do PCPs not do the testing on a regular basis?
Maybe Dr. Dworkin, do you want to take that? Or others? Sorry.
Let the record show that we follow the CDC's recommendations. I'm going to answer the question, but in a little, slightly broaden the context. So the specific indications for lead screening, as you well know and as you've taught us, are driven by environmental circumstances and the likelihood of securing a positive screen. And one perhaps could debate, based on a variety of factors, whether universal blood lead screening should be done. I think there's room probably for negotiation at the local level, and I'm watching my CDC leaders hopefully shaking their head yes. But let me answer in all seriousness, provide a little broader perspective. Screening for any issue must not be performed in isolation. That is, screening is only worthwhile to the extent that screening leads to referral and linkage and remediation of, if possible, the underlying factor contributing to the abnormal screen. So the notion of screening, for example, for lead, particularly as we get down to quite low but harmful lead levels that have profound environmental implications, should, I would propose, be most enthusiastically expanded within communities that have the capacity to deal with the results of that screening and deal with the increased lead burden present within a community. Final thing I will mention is we opened an office for community child health at our medical center about 3 years ago. We have 14 community-oriented programs under the banner of this office. I would say one of certainly the most impactful programs is our Connecticut Healthy Homes program, which actually has to date abated some 4,000 homes from lead and other hazardous environmental influences on children's development. So I think follow the CDC recommendations. I think there is room for discretion at the local level, depending upon your demographics. And always remember that screening discussions should always occur in the context of the response to a positive screen.
So I think while we take another one from Susan, if people have questions in the room too, there's microphones on each side that you can come up to.
What is the impact of culture on health disparities in early childhood? Are there any current studies of such significance? And if so, can you identify the communities impacted?
Does anyone want to take that? Dr.
Well, I'll offer a brief response just in the context of what we're talking about today, early detection, referral, and linkage. And we've done some research a number of years ago that has shown that expectations for children's development, expectations around developmental milestones, if you will, are heavily informed and in fact driven by cultural beliefs. And so it is extremely important when we engage families, and as we recognize the importance of eliciting parents' opinions and concerns, which are so critically important to promoting early detection, that we be mindful of the relationship between cultural beliefs and those concerns.
Dr. McCabe?
Yeah, just one other thing to add to that. I can't cite specific studies, but I know that there's been an enormous amount of work about help-seeking behavior, and particularly help-seeking behavior for parenting programs in the Southwest states, where there is a large regular immigrant population and agencies that treat border families. So there are resources for that writer to seek.
Maybe Cindy Hinton?
Yeah. Hi, Cindy Hinton with the National Center on Birth Effects and Developmental Disabilities. And thank you so much for a wonderful panel. It's really great to see this, getting this kind of exposure here at CDC. I have a question about specifically what you were addressing with the silos of care and particularly how we can get some of the outcome data. I know we've talked a lot amongst ourselves. Like education data would just be, key. I've worked in the area of public health newborn screening before. It's come up in a number of I could see it fitting in with, either environmental exposures, trauma exposures. We have public health newborn screening. Are any of you aware of novel ways that states have worked within education to try and make those linkages? It would just open up a world for us, and yet it remains very challenging. Thank you.
I would quickly refer you to Kelly Kelleher's work in Ohio. He's doing some really innovative cross-community work, not just limited to education and health, but other sectors as well. I should mention, though, there are some obstacles to be addressed, and that includes data sharing. It's a huge obstacle, and protections under FERPA for school data are not necessarily compatible with protections under HIPAA for health data. So data sharing is a huge obstacle.
I would just add that in the many states that we visit in our Help Me Grow technical assistance work, the number one issue is how do you share data across sectors to get a comprehensive, accurate accounting of the status of children's healthy development. HIPAA, FERPA are issues, but from what we've been told multiple times by many attorneys across many venues is the perceptions are actually far worse than the realities. That is, the legal realities can be fairly easily maneuvered in support of care for children. And secondly, we're hearing from an increasing number of states, including Connecticut, that are moving to unique identifiers at birth that will follow children through across all systems. That is a critical aspect of solving this challenging problem.
Dr. Boyle?
So I have a question about bringing programs to scale, and what is scale? So Dr. Thompson, you talked about two great programs, the Nurse Home Visiting Program, as well as that Chicago-based program. Dr. Dworkin, you talked about a system, an integration of programs within the context of Connecticut. I think I wrote down the percentages of children that each of these systems or programs might impact. One is 12 to 16% of children delayed. The other one is 30 to 40% of children at risk. So obviously what we're doing right now is hitting just a small fraction of each of those buckets. So your thoughts about bringing to scale and what scale represents in our context?
That's what I get for not speaking up earlier. Scalability is one of the big issues we're facing here. And part of it is the realization, especially in the early childhood community, that we are generalizing widely from some very small scale programs, and that there are challenges involved in trying to bring things that work in small demonstration programs when you are scaling up. Nevertheless, part of the reason I chose the programs that I do is that they provide good models for how scalability can be achieved. In the Nurse-Family Partnership Program, actually, the administration has been helpful in the maternal and infant and child home visiting program in providing both a funding infrastructure for supporting the use of this program and other home visiting programs in multiple jurisdictions around this country. But also, and this cannot be emphasized enough, imposing measurable indicators of quality in deciding on which programs to support or not. It is part of what has been a little recognized administrative initiative in trying to use evidence in its selection of program models. Ron Haskin's book, Show Me the Evidence, is a good recent analysis of the successes of this. And so I think that if we're able to focus on quality, if we have, as in the Nurse-Family Partnership, a broad base of public support in federal agencies, that scalability can be achieved. In the case of the early education space, part of the reason for using the Chicago Child Parent Centers is that was embedded in a very large school district. Likewise, the Abbott Preschool Centers, which I think you will be hearing about soon, because of evidence now dating later than fifth grade, showing a long-term impact from a court-mandated early education program, particularly targeted for children coming from economically disadvantaged settings, is also located in a large public school system. In each case, I think the emphasis is on choosing programs that are of high quality, focusing attention on duplicating that quality in local replications of the program, and then having a secure funding base to do so.
So I would just very quickly add 2 points. One that Ross mentioned, funding sustainability in order to bring to scale. And I think the answer in part lies in Mary Ann's reference to blending of administrative and financial resources across agencies and integrating our efforts much better together. Secondly, I think, to quote Cool Hand Luke, what we have here is a failure to communicate. I mean, I've been so impressed, even within Connecticut, a small state, how getting the message out about the services that are available to families are so difficult to make known. So that when we do this at the very local level, so when towns, communities take on Help Me Grow campaigns, we see the numbers skyrocket up. But it takes that type of concerted local effort, because all politics is local, and the right language to help families understand that engaging with a state agency does not necessarily mean that they may be at risk, for example, under the Child Protective Services banner, to quote just one of multiple factors.
So I think we'll take one more question from our web audience.
In understanding rates of diagnosis for 2 to 8-year-olds, as was stated in the presentation, was there any assessment of rates of child maltreatment or trauma in conjunction with the diagnoses?
I can answer it just a little bit. I think there are such large-scale federal surveys that I'm not sure that there's a chance to dissect on a case-by-case basis whether there's also been an incident of child maltreatment, but that would just be my guess.
Okay, sure. Pardon? No, you can go ahead. That's fine.
Actually, I can't speak to Dr. Egger's data, though, although I know that there is a wide-ranging kind of assessment of family and child circumstances that goes into the PAPA, the pediatric assessment for a psychiatric diagnosis.
Okay. All right. So, well, I'd like to thank our speakers today, and I think Dr. Thorpe has something to say. Okay.
No, let's give them a round of applause and thank them. And thank you for joining us, and please join us next month.